Hello everyone, I welcome you on the Online Institute for this web conference on challenging ceramic restorations with freehand bonding. The illusion becomes reality. It's a pleasure to share the next hour with you, discussing new concepts and clinical procedures regarding the treatment of anterior teeth with direct bonding. I will start with the first case, showing 6 anterior teeth which have been broken during an accident, a sport accident. We are faced now to a very classic situation. We have some missing dental tissue on the 3 upper and 3 lower teeth. The question is, of course, which treatment option should we select? I think we can all agree that full crowns will not be a very good option. If we place ceramic veneers, we'll have also to remove some healthy tissue, which I don't like too much. So for me, probably the best treatment option is for sure direct bonding, and you will see now the post-operative situation with a perfect integration of the composite restorations. You have actually a direct transition from the tooth substance to the composite material, and this result was not obtained because we used a very complicated layering technique, but because we selected the material with the best possible optical properties, and that's what I'm going to explain during this next hour. We can also achieve outstanding results with direct bonding on the posterior teeth. This is not the topic for today, but just to give you a little input about the use of direct composites on the posterior teeth as well. You see here some restorations during, or some fillings, composite fillings during the placement of the material. You see the light curing of the material, just to make sure that you have no doubt about the technique that we used. We speak here about a direct filling technique, and you see the kind of anatomy we can achieve. We don't need to use indirect restorations necessarily to obtain a perfect aesthetic result, a good anatomy, and of course a good function. You can also see that we have here a perfect proximal contact. This is also something which is rather easy to achieve with direct bonding. You see the situation. After occlusal adjustments, we had to do minor corrections, as the sculpting technique we used was really creating almost ideal function, and the time which is needed to adjust occlusion is really minimal, and that's really one significant advantage of using a sculpting technique. Now let's go back to anterior restorations. You see another case, which is actually not a recent case, but once again an accident, a trauma. This patient lost a quite large part of this left central incisor, and as of course this is an emergency situation, we have basically only 2 options: either to make a temporary crown, and of course to prepare the tooth for that, or to make a direct composite restoration. In order to stick to our conservation principles, I decided to place a direct composite restoration. You see here the case shortly after removing the rubber dam, so it's still bleeding a little bit around the cervical margin. We also can observe the slight difference in the translucency of the composite material and dehydrated tissue. That's absolutely normal at this point of time. Now let's have a look down the road. You see now the situation 3 years later, with exception of a little porosity. we have satisfactory aesthetic integration. We have been able to maintain the vitality of the tooth. We have no functional problem. We have also no interference between the restoration and the soft tissue, which is something that I like very much, especially for a case like this, where we have a very thin periodontal tissue. This kind of tissue is likely to recess if we try to place a crown margin inside the sulcus or close to the tissue. We can now have a look further down the road. You see the situation 5 years later. We can still say that we have an excellent aesthetic integration. 6 years later, and finally 10 years later. 10 years later, we still have a little problem here, discoloration, but this is really a minor problem, certainly not even visible at a speaking distance. But otherwise, we see that we have a reasonably acceptable color integration. No major problem with the adaptation of the restoration, nothing like marginal discoloration or signs of micro leakage. The function is good. The vitality of the tooth is still here. And we can say that after 10 years, we have a perfectly satisfactory situation. And actually, at 10 years time after placement is normally what we expect with a prosthetic restoration. And I think that with modern composite materials, we stay pretty much within the same time frame as regard aesthetic integration. So it's not true to say that only ceramics can provide long-term aesthetic results. In this type of indication, we can also achieve excellent results with direct bonding. And I think that direct composite restorations better serve our needs to maintain long-term aesthetic integration and tooth biomechanics. You see here another case. This is a young patient who also lost a large part of this left central incisor, but with exposure of the pulp in this area. And this restoration that you see here on the X-ray was rebonded a few times, and that's actually what you see here, because this was not properly bonded to the remaining tooth substance. And if you look at the clinical situation, you see the severe inflammation, which is the result of the poor restoration adaptation. I have also to mention that the tooth is symptomatic to pressure, to cold, and heat, which is a sign of pulpal inflammation. That's also the result of a defective seal of the restoration at the gingival margin. So what kind of option do we have to restore such a tooth in a young patient at the age of 15? That's actually, there are actually not so many options, and what we decided to do here is a direct composite restoration after placing the rubber dam. You see here the first increment of the restoration, which actually is a flowable material. This will allow us to adapt the restoration quite well to the gingival margin, as we cannot place a wedge at this point of time. And only after I've made this first increment, I can place the matrix back on the tooth, wedge the matrix or stabilize the matrix with the wedge, and go on with the next layers. We have used, of course, some enamel, some dentin material, effect materials, and I will detail those different steps a little further, a little bit later. And now you see the final situation on the X-ray. We have a perfect adaptation of the gingival margin. We have made a new direct pulp capping, and we are back to a satisfactory situation from a biological standpoint and also from a clinical standpoint. And the aesthetic integration of the restoration is, I hope you can agree, acceptable. It's never perfect, but it is a satisfactory aesthetic integration. But what is even more important in my eyes is that the soft tissue is back to a healthy situation, what you can observe here on the X-ray, and the symptomatology has also disappeared. So this is really a perfectly satisfactory situation. And to come back to the comparison with porcelain or porcelain-fused to metal restorations, you see here an example of the 10-year results of 2 PFM crowns placed on vital teeth in a young patient, and you see the typical aesthetic problem we have sometime after placement, not a couple of months, but sometimes a couple of years later. Loss of aesthetic integration due to the remodeling of the gingival tissue. And as soon as the margin is exposed, these will eventually get discolored, as here. And of course, the patient is not satisfied anymore with the restorations. So in some cases, direct bonding can even provide better aesthetic results. Also, something which is very important in my eyes is the long-term maintenance of prosthetic restorations. You see here a very advanced case. Those relatively poor prosthetic restorations were placed about 10 years ago, and you can visualize the many problems we have. We have problems with the gingival profile, which is absolutely not symmetrical. We have a problem with the exposure of prosthetic margins and severe discoloration of the dental structure. And in order to give this patient a new smile back, we know that it will be a long and difficult treatment. And you see the final result. We had, of course, the collaboration of an excellent, highly skilled dental technician. But before we were able to place those full ceramic restorations, we had to redo the endodontic treatments. We had to do new post-in course. We had to use 2 generations of temporary crowns. This is a lot of time. These are a lot of efforts which are involved, and of course, in a private system, this will be a very costly treatment for the patient. So I think we also must include this parameter in our decision process. Now I would like to cover very briefly the indications of freehand bonding. We still have classical indications like class 3, class 4, and an incisal build-up is for me just a modification of the class 4, or it's an extended class 4 restoration. We have the class 5. A very important indication today, cosmetic enhancements. There are many situations we can improve with direct bonding. Veneers in some compromised cases, usually in young patients or patients with very strict financial limitations, and mixed indications. It means we can combine composite and ceramics in the same case. You see a typical class 4 case now with a few steps. Once again, a sport accident that we treated with direct bonding. The first step is the mock-up. It's not an aesthetic mock-up. The mock-up is actually aimed to restore the incisal edge position and width of the tooth. We can record this information through a silicone index, and then use a silicone index to guide us during the build-up of the different layers. I will detail all those steps a little further. But you see now the final aesthetic result, showing a good color and translucency integration. We have been able to recreate a palisades effects we have in the natural tooth structure, and I really think that in this situation direct bonding as really a very good potential. And actually, freehand bonding should really be part of our dental armamentarium today. We have very conservative treatment options, and I really believe that freehand bonding belongs to this group of conservative treatments or conservative options like orthodontics, chemical treatments. We can use vital bleaching, non-vital bleaching, or microabrasion to improve the color of natural tissues. Enamel recontouring, that's a quite common procedure after orthodontics. And then we have the second group of restorations like veneers, adhesive bridges, implants, and full prosthetic restorations that I personally consider is really the very last option. That's what I have called the progressive treatment concept. And really I think it makes sense to really start with the most conservative treatment options, and only later on, or if we cannot fulfill treatment objectives, to maybe select a more invasive treatment option. I'm returning to the normal menu to open the second part of the presentation, and I will switch back now to the full screen menu. I really believe that it's much more interesting for you to have a full view of the pictures rather than to see my face on the right side of the screen. Now I would like to describe the layering concept that we use for doing those highly aesthetic anterior composite restorations. It's a very simple concept to which I've given a name, which is actually the natural layering concept. What does it mean? It means simply that we try to mimic nature. And as we all know, a natural tooth is made of dentin and enamel. I will just ignore, but it's logical, I will ignore the pulp, because of course we do not try to replicate the pulp in any restoration. So we try to build up a restoration in the same way a natural tooth is constructed. So what could be the ideal characteristics of material aimed to replace dentin? First, and this is directly derived from measurements we have performed on natural tissues. First, we use a single opacity material. We don't have opaque dentines, regular dentines, or translucent dentines. We have one single opacity level for every shade. Then, what might be surprising to you, we use a single or the same color for all cases. If I refer to the Vita Shade Guide, we will certainly use only the A shades. In this concept, we prefer to use materials which have a universal dentin color. And I will mention a few products we have which have been developed according to this concept. What is certainly necessary is a large chroma scale. It means from very light shades, dentin shades, to very dark dentin shades, and I will explain why. And we would like to have a material which is fluorescent, like natural tissues. If you look at the shade guide, and this one is from the system Miris from Colting Weldon, this one shows actually the 7 different dentin shades from S1 to S7, which all have the same basic color, what we say from a scientific standpoint, U, but we have an increase in chroma. These are the light shades, and all the way to the right we end up with the darker shade. That's a very simple shading concept to work with. Things are unfortunately a bit more complicated as regard to replacement of enamel, because in nature enamel is a more complex tissue, it shows many more variations compared to the dentin or tissue. And actually, in order to make the concept as simple as possible, we selected 3 types of enamels. This is actually also a concept that we find in some ceramic systems. We have a first type of enamel, which is for white teeth or young teeth, and you see here an example with young teeth showing beautiful apalescent effects. This is actually really typical from young teeth. A relatively white enamel, which is definitely less translucent than the enamel we see in either adult patients or older patients. You see here an example of the type 2 enamel, which is a more neutral enamel. This kind of universal enamel we observe in adult patients. It has a more neutral tint, it is less apalescent, and it has a medium translucency. That's really the basic concept for the type 2 enamel. And we have the type 3 enamel, which is sometimes more grayish or yellowish. In every case more translucent than enamel in young or adult teeth. And you might see here sometimes with a digital picture we lose some color details, but if you look at especially proximal enamel, it looks more grayish than bluish, and that's certainly related to an increased translucency of the tissue. And it can have, once again, either a yellowish tint or also sometimes a higher translucency. These are actually the characteristics of type 3 enamel, and with these 3 types of enamel we can reproduce pretty much all variations we observe in nature. And we were interested to confirm this concept, which initially was derived from the observation of natural teeth. And we made measurements, and especially of the contrast ratio, which is one way to evaluate the opacity or translucency of a sample or a tissue, for instance, here. And you see that between the white enamel and neutral and ivory enamels, which actually is enamel taken from young teeth, adult teeth, and old teeth, you have a clear decrease in the contrast ratio, which means there is a decrease in the opacity of the tissue. So actually we have been able to confirm or to give the proof that this concept is really a good imitation of the nature. There is a third component in the natural layering concept, which is actually effect materials, or which are the effect materials. We need, for some cases, additional colors which will allow us to reproduce some specific features of natural teeth. For instance, blue effect material that we normally use for simulating opalescence, white opaque effect materials we can use to simulate all kind of white spot and demineralization areas within enamel, and a gold effect material, which is normally made with the same pigments as the dentins of the composite system, which we can use to control the chroma of the restoration. And you see here a few examples. Those are actually full composite teeth where we used different effect materials. You see here some white effect material we used to replicate a white spot. This is maybe one of the most common effect material that we use. The blue effect material, mainly used in young teeth to simulate the opalescence. You can see it either from a buccal perspective or from a lingual perspective. And the application of the gold effect material that we use in some areas to increase the color density, to increase the chroma. I like to call the gold effect a chroma modulator. That's something we use sometimes when we have a higher chroma that we want to increase the chroma of the restoration. And you see here a few more examples of full composite teeth we have fabricated with a composite system. Once again, here this is the mirror system. This is one of those systems which have been developed according to the natural layering concept. You see here, for instance, the comparison between a real tooth, a natural tooth, and a composite tooth. You can see how similar are the effect of translucency, opalescence, color, surface loss. It means that we can replicate very, very well all effects we can observe in natural tissues. There is a last concept that I would like to share with you as regards natural aesthetics, which is the dynamics of natural aesthetics. What does it mean? It means that some characteristics, optical characteristics of the tooth or the dental tissues will change over time and with function, like dentin chroma, the tint of enamel, or the translucency, opacity of the tissue, but also some relations, spatial relations between dentin and enamel. And I would like to explain this with first a few clinical pictures and then drawings to better understand the differences which exist between a young tooth, an adult tooth, and an older tooth. You see here a relatively young smile. And I would like you to compare this image with the next one. I think the difference is quite obvious. And what is certainly the main difference is the color, the high chroma of those central incisors compared to the previous smile. And just returning quickly to the previous image, I'm quite sure we can all agree that the main difference between those two images is the high dentin chroma. But then if we further analyze the differences between those two images, I'm quite sure you can see that here the dentin is coming up to the incisal edge. The incisal edge has been shortened by wear. This is actually the result of the function. And this will completely change the spatial relations between dentin and enamel. So let's review now, or let's have a look now to a drawing explaining the internal structure of a young tooth. In a young tooth, the dentin core is fully surrounded by enamel, and this is actually very typical of a young tooth which has not been submitted to excessive wear. And if you look at natural samples, and what you see here are natural dentin cores after the enamel has been chemically removed. We are able actually to dissolve selectively enamel to reveal the internal structure of the tooth. And you see here natural dentin cores from young teeth. And if you compare those this situation to the situation of an adult tooth or an older tooth, we must realize that the relation at the incisal edge is quite different in an adult or old tooth compared to a young tooth. And actually, if we look at real samples once again, you see not only the differences in the dentin chroma. Obviously, those dentin cores have a higher chroma. We see a darker yellow. But also, if you look at the incisal edge, we have a perfectly flat incisal edge. Those little points or mamelons have been worn away by function. And further, where we have more dentinal tissue will be exposed at the inside edge. So we must just recognize those differences whenever we make a composite restoration on a young adult or old tooth, because otherwise selecting the right dentin chroma, the right enamel translucency or tint is not enough to get a perfect aesthetic result. We must also apply each material in the right place and in the right proportion. I'm switching now to the third part of the program and back to the full screen. Just to summarize, what we have discussed so far is very simple. We have this natural layering concept which makes use of a single dentin shade but with varying chromas. It means we have light dentin shades and darker dentin shades. We have different type of enamels with a white, neutral or yellow-grayish tint and different opacity levels. And then after we have selected the right dentin and enamel, we must still apply each mass in the right proportion, in the right position in the inside edge to take into consideration the age of the tooth. So I think this is a quite simple concept. Now I would like to detail all clinical procedures. And I think we must be extremely systematic in the way we realize the restoration. You see here the treatment sequence. My proposed or my preferred treatment sequence. I always start with the shade selection first. Why do we start with the shade selection first? It's very simple, because we want to analyze and evaluate the shade before the hydration of the tissue will occur. And this can occur very rapidly. That's the reason why it's better to start first with shade selection. Then, if needed, we will proceed with a few diagnostic steps. That's normally for advanced cases. Then we'll do the restoration build-up, and of course last, finishing and polishing. So that's a very simple and logical treatment sequence. Let's speak about the shade selection. I would like you to forget about what you normally do for ceramic restorations during a few minutes. Selecting shade for a composite restoration is a slightly different process. It's normally a three-step process. First one being the selection of dentin chroma. Second one being the selection of the right enamel tint and translucency. And the third one being the selection of effect materials. But let's explain in more details how we proceed for the selection of dentin chroma. And it's intentional that I'm speaking about dentin chroma, because if you remember, in the natural layering concept there is no need to select the basic color. We have one single basic color or basic hue. So actually I want to select the right chroma. If I look now to those two samples, those are two incisors coming from the same patient. One is intact on the right hand screen, and on the left side we have the neighboring tooth from which enamel was removed. Now if you look at this sample, as you can see, we have a perfectly uniform appearance of dentin, except the incisal edge where we have some translucency effect. But if I look at the full tooth, there is an apparent decrease of the chroma. This is actually the filtering effect of enamel. Enamel reduces the apparent chroma. It means I will have eventually some problems to select the right dentin chroma in the middle of the tooth or close to the incisal edge. That's the reason why I prefer to go in the cervical area in order to select the right dentin chroma. And we confirmed this approach by analyzing with a spectrophotometer the real or the true dentin color of teeth with or without enamel. You see here the full tooth, simplified chromatic map, extremely simplified, detailed chromatic map, and the same tooth. And this map, which I personally think is very interesting, the map of the tooth with 3/3, the cervical, the medium, and the incisal thirds. What you normally measure in this area is actually related to enamel, translucency and apalescence of enamel. It doesn't relate too much to the real color of the tooth. If you want to evaluate the real color of the tooth, you must take into consideration the cervical part of the tooth. And actually, if we look at the same tooth, but after removing enamel, you see that we have a rather uniform dentin substrate. That's exactly what I was explaining before. And this can be very nicely shown on the spectrophotometric measurement. You can look at the coarse map and the detailed map, or also the map in thirds. We pretty much find the same color. We'll just avoid anyway to evaluate the incisal edge area because we have some translucency effects also at the level of dentin, which will perturbate the color evaluation. This is just to prove how much important it is to go in the cervical area rather than in the middle of the tooth to evaluate the true dentin, not color, but the true dentin chroma. The second step is the evaluation of the enamel tint and translucency. This should be something relatively easy, because actually what I normally do is just to observe the teeth and decide whether it is a relatively young tooth with a white apalescent enamel, or is it a neutral enamel, or is it a yellow, grayish, translucent enamel. So that's something which is normally quite easy to evaluate just by visual observation. The third step is the selection of effect materials. We do not need effect materials in every single case. Maybe I use it once over 5 cases or 6 cases. It can be, for instance, the incorporation of a blue effect material to simulate apalescence, white effect materials to simulate a white spot, or a gold effect materials wherever I have increased chroma. And you see here on the same picture but with enhanced colors, you see those 3 different effect materials we can use to improve the final aesthetic result. But once again, I want to make sure that I've really pointed out the fact that we use effect materials only in some selected cases. So now let's return to clinical reality and have a look to the instruments we can use to select color. The first possibility you have, if your system has been developed according to the Vita shading system, the classical Vita shading system, you can use the ceramic or the ceramic shape samples which are provided in your Vita system. This might help to select the basic dentin chroma, but this will not give you any information as regard the surface material. But that's one possibility. The second possibility you have, what I've been doing for years, is to fabricate your own shade guide for both dentin materials and enamel materials. At the time you select the dentin chroma, you go close to the cervical area with your dentin composite sample, and when it comes to the selection of enamel, you will go usually in the incisal or proximal area to select the appropriate enamel material. And we will follow the same concept. We will try to identify the correct tint and translucency of the enamel material to be used. What might be actually the most advanced concept to select shades for composite restorations, dentin and enamel shades for composite restorations, is the shade guide which was developed by Colton Weldon. You have two separate shade guides, one for enamel, which have a shell shape and a thickness or a configuration which very precisely mimic natural enamel, and you have also a second set of dentin shade samples which have smaller dimensions and also dimensions which are very similar to a natural tooth. And the interesting concept which is behind this dual shade guide is that you can insert the smaller dentin samples inside the enamel ones, providing you have placed a drop of glycerin gel in between the two samples. The reason for that is very easy. It will prevent the light to be reflected at the interface between the two samples. So glycerin gel is having pretty much the same refractive index as the composite material, so that it will give you a very accurate perception of the superposition of dentin and enamel, so that you can really compare the effect provided by using this particular dentin and this particular enamel when they are combined together. So that's a very unique feature of this layering shading system. Now we go to the next step, which is actually the diagnostic step. This is necessary for some advanced cases. For instance, here we have a set of 6 teeth we would like to build up with composite. We would like to clothe the diastemas, we would like to reshape the canines and the premolars, but we are not sure whether we'll be able to create an aesthetic composition and obtain a satisfactory function. So it is absolutely logical to fabricate study casts, to mount them into an articulator, and to ask the dental technician to make the wax up so that we can visualize and analyze the final result. And if we are satisfied, we can go on with the restorations. In some cases, simple cases, we still want to evaluate the final aesthetic result, but we do not necessarily need to have this diagnostic phase performed by the lab. Here, for instance, we would like to close the remaining space in between the central and lateral incisors. Actually, this is not a lateral incisor, but this is a canine which was transformed into a lateral incisor. But to make sure that we can end up with a pleasant aesthetic result, we apply composite directly on the teeth in the mouth. This is what we call a direct freehand mock-up. And once again, according to the aesthetic visualization of the treatment, we can decide to proceed with the restorations or not. Whenever we have made a mock-up for transforming a tooth shape or for a large class 4 build-up, it is very helpful to fabricate a silicone index from this mock-up. And this will be extremely helpful for the build-up of the restoration. This will allow us to be much more precise in the way we apply dentin and enamel in the incisal edge area. Now I would like to come back to the layering concept, or to the shading concept. The one concept that I like very much is the one that I have described before. It is the natural layering concept, or what has been called as well the trendy layering concept. This is from far the easiest and most logical approach for anterior composite restorations. We have only two basic layers: dentin, possibly some effect materials in between dentin and enamel. But the basic layers are only two, dentin and enamel, so that we build up the restoration exactly as the natural tooth structure. I'm switching now to the fourth part of the program, and as soon as the first image will show up, we'll move back to the full screen menu. And you see here actually the different materials which have been developed according to this concept. From an historical perspective, there is first the enamel HFO, or Vital Essence, in the United States. This is actually the same product, but with two different brand names for Europe and America. We have Miris from Colton Weld, and we have the Artemis or Four Seasons, which is an Ivoclar product. According to the type of enamel you work with, you can actually use or not, or follow or not, the natural layering concept. And the Theram X from Dentsply Dutch-Ray, which is a new type of composite material. This is a normal air technology, and it has been also developed according to this concept. So you see that you have different options which are available for using or to practice the natural layering concept. Now I would like to go through a step-by-step description of the natural layering concept. You see here the preoperative situation, and this is actually the first case I would like to describe. We have a rather large build-up, pretty much 1/3 of the incisal edge, and from a lingual perspective, you see that we have an even larger amount of tissue missing on the lingual side of the tooth. So it's a very interesting case to describe the natural or trendy layering concept. You see the situation after the preparation. I don't want to comment too much the preparation or the margin design, because we know there are many different margin designs which all give excellent aesthetic results. The one margin design that I have personally selected is a 45-degree bevel, which is about 1 to 1.5 millimeter. And well, I'm personally quite comfortable with this margin design. So you see the preparation we have with a relatively large amount of tissue missing, and the first application of the lingual enamel, which is made directly against the silicone index. And this will be, as I said before, extremely helpful, because this will give me in only one step the whole shape of the incisal edge. It will give me the width and the length of the incisal edge, and this will allow me to make a very precise placement of dentin. You remember the three different types of teeth we have: young, adult and old, and according to the age of the tooth, I must come closer or not so close to the incisal edge. And that's the reason why it's so helpful to have first the palatinal or lingual enamel placed on the silicone index. So I will try to underline the position of dentin here, so you see that I'm staying pretty much 1 millimeter away from the incisal edge. It's actually the position of dentin. Then I will use some blue effect material, which I will actually place in between the mamelons. I will feel the small concavities which I've created in between the dentin mamelons before I will cover the whole buccal surface with enamel. So you see, this is quite simple. I just return very quickly to summarize once again the technique. We have the first palatinal or lingual buildup, which is made of enamel. We have then dentin, which is placed according to the age and specific configuration of the incisal edge. Then the blue effect material should be a small amount that we place pretty much in this area. We almost do not see it, it should be very discreet. And finally the buccal and proximal enamel. It's a very simple and logical approach, and you see here the final result with a very good color and translucency integration. We see it in a black and white perspective, which allows us to evaluate the value of the restoration or the brightness of the restoration. We see the same restoration from a buccal perspective. I will come back to the finishing later on. Second case is a different case. It's a shape modification of two peg-shaped laterals, and direct composite application or freehand composite is really, in my eyes, the ideal technique to make such a transformation. Eventually we will need some orthodontics to realign the whole front teeth, but if we don't go for orthodontics, direct bonding is certainly the best treatment option, so that we keep the teeth absolutely intact. We'll start first with the shape selection, as always, selecting first dentin trauma, bringing the shape sample close to the cervical area of the tooth, then combining one enamel and the selected dentin, and evaluating how well the samples match the natural tooth structure. Then we removed here, for instance, the little class 3, we cleaned enamel, and we etched. After applying the adhesive system, we are ready with the buildup. What we actually do is to use a little bit of dentin to fill a part of the space which exists in the embrasures. We cannot fill the entire volume only with enamel, because otherwise too much light will go through the embrasures. This will make the embrasures extremely gray, or it will be too much translucency in these areas. The second step is, or the second layer is the blue effect material, then the white enamel. We use also here a clear, pre-shaped, pre-formed matrix. That's the one from Haveneos, this Lucifix system. And this will give me a very nice emergence profile. I'm following now the emergence profile which is given by the pre-shaped matrix. This will reduce the number of increments which are needed to really create the normal emergence and proximal profile of the tooth. But this view is very interesting because you see the three components: dentin, blue effect, and the enamel. This is as simple as what you see on the screen. And you see the final result. Left side, the left lateral, which was actually in a rotation, and the right incisor that you see from a buccal or lingual perspective. You see the appearance effects which have been created by the blue effect. You see a correct translucency and tint of the enamel, and with this really extremely simple layering technique we can achieve really excellent aesthetic integration. A third case, which is a more advanced case, this is a patient which was treated for missing lateral incisors, and orthodontists have moved actually the canines, or actually have moved mesially all the teeth distal to the central incisors, which result, of course, in some aesthetic and functional problems, since you have canines into the position of lateral incisors. On top of that, you see some obvious white discolorations which are related to a mild fluorosis. You see other views of the case. You see the smile view, you see the lateral views, you see the kind of aesthetic problems we deal with. And since the patient is a relatively young patient, the patient is only 16 years old, we decided to proceed, at least at the first approach of the case, with very conservative restorations, which will be direct composite restorations. Prior to the restorations, we had to do a little bit of perio surgery to remove some hypoplastic tissue we had around the canines. This is quite easy, and also to lengthen a little bit the premolars, to give them proportions which are much more similar to canines, because we have to reshape not only the canines but also the premolars, trying to recreate the normal configuration of an anterior smile. We also use microabrasion to remove as much as we can these white discolorations, because otherwise recreating this white discoloration into the new composite restorations is not really logical. So it's better to remove the discoloration first and then rebuild the teeth without the need to use too much white effect material. So you see here the situation at the end of the microabrasion procedure. We have removed very much, not completely, the white discoloration, but a large part of it. So you see now the situation after microabrasion. Also after remodeling the buccal surfaces of the lower teeth, which have been unfortunately really not properly managed during or after the removal of the brackets. It was the enamel was left with a lot of irregularities and traces created by the burrs. It was something quite easy to perform before going with the further steps. And then we come to the final step, which is the reconstructive phase, by adding just a little bit of composite to close embrasures in between the future lateral incisors and central incisors. We have also slightly enlarged and corrected the distal edges of the central incisors. That's a very simple restoration, or very simple type of composite restorations. And you see now the final aesthetic situation with enhanced premolars. We actually reshape the premolars into canines, canines into lateral incisors, and also enlargement of the two central incisors. This is not a perfect, absolutely perfect case, but at least we came much closer to a natural configuration. I would definitely say that this orthodontic approach to missing lateral incisors is not my preferred approach, but well, when you are left with that situation, I think that this combination of conservative procedures like conservative periodontal surgery, microabrasion, and direct bonding is probably the very best option we have for a young patient. You see once again the full smile. It's not perfect, but I think you can certainly agree with me that this is a significant improvement. Let's finish the description of the natural layering concept with the finishing and polishing step. This is a very important step. This can really make a significant difference between an almost perfect restoration and an average restoration. And in order to achieve the best possible result. It is not so important which polishing instruments or finishing instruments you use. It's much more important to respect anatomical references, which are listed here. Proximal contours. The buccolingual profile accused is not flat, it's curved. The buccal surface is convex, the lingual surface is concave, so we must be sure that we respect this natural profile. Transition lines which will separate proximal surfaces from the buccal surface. The position of the incisal edge, but this is quite easy because it's given by the neighboring teeth, and the surface micromorphology. Those 5 anatomical parameters are extremely important, and if we are able to recreate or to respect those different parameters, you should end up with really a very good aesthetic result. So now let's return to a clinical case and analyze together the different steps once again. In order to define the general shape of the tooth, which are actually the proximal profile, the incisal edge position, general buccal profile, this I will perform with soft discs, and my preferred instrument is clearly the Poppen XT disc or similar instruments, which are relatively small, thin, small as regard the diameter, thin, and still stiff enough to allow us to have a good control of the finishing step. That's really my first instrument, and only when I have defined the general shape of the tooth, I will go with fine diamonds or finishing carbide instruments, both. And I will do fine corrections like on the incisal edge or the texture. The texture I will recreate or create with horizontal and vertical motions of a fine diamond or a finishing carbide burr. And you see the traces left by the burr on the composite surface, trying to recreate the small waves you can observe on the natural tooth. It's a very delicate part of the whole procedure, but if you observe carefully the surface of the neighboring tooth, you should obviously be able to imitate the texture or create the desired texture into the composite material. And the last 2 instruments are rubber points and brushes, which will allow you to smooth a little bit the surface, to create those smooth waves on the composite surface exactly as you see it on the natural tooth. And the brushes, hard brushes, are quite helpful for getting the final gloss. You can also use a soft disc with some kind of polishing paste. It also works beautifully well. That's here, for instance, the soft wheels from Cosmonin. That's also an option that I like very much for the polishing of the composite surface. But whatever instrument you like should normally be fine. So with that last image, I've completed this overview of what I consider is probably the state of the art in freehand composite restorations. And I would like to thank you so much for your kind attention. It was a pleasure really to be with you today. I really hope you did enjoy this web conference. I thank you, the Online Institute, for inviting me on this web lecture program, and I'm very much looking forward to see you again on the Online Institute. Okay, thank you and goodbye.